Good morning. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar K. Please don't forget to subscribe my channel and also please give your valuable comments. So as we know, in the last class we are discussing about the red cell indices, MCV, MCHV, then PCV, red cell count and all those things. The last point that we are discussing is red cell distribution width. Red cell distribution width. So red cell distribution width means this indicates the variation in the size of the red cells. That means there may be a microcytic cells, there may be macrocytic cells, there may be megaloblastic cells in the circulation. So red cell distribution width, that gives a rough idea about the different types of size of the RBC present. So this helps to identify the percentage of microcyte, what is the total percentage of macrocytes which are present, normal cells, and what is the percentage of macrocytes which are present in the circulating blood. So if you got that percentage of macrocyte is more, then we can come to a conclusion that preferably this is a macrocytic anemia. Problem may be many. Or if microcytes are more, then preferably it can be a iron deficiency anemia, maybe a nutrition anemia, iron is deficient. So you can come to this particular conclusion by this red cell distribution width. So usually this red cell distribution width is seen in combination of megaloblastic and iron deficiency anemia. Usually जो है ये मिलता है हमें आयरन डेफिशिएंसी एनीमिया या मैक्रोसाइटिक एनीमिया या मेगलोब्लास्टिक एनीमिया का कॉम्बिनेशन में, ठीक है. तो यूजुअली RDW रेड सेल डिस्ट्रीब्यूशन विड्थ जो है वो बहुत हाई होता है इन केस ऑफ आयरन डेफिशिएंसी एनीमिया एंड मेगलोब्लास्टिक एनीमिया. द डिटेल्स वी विल सी दी इन द लेटर पार्ट. So now already we are discussing about this red cell distribution. Today we will see another important topic related to same, that is analysis of the CBC in the childhood clinical practice, complete blood count. So this is a very important thing. In the complete blood count, one portion, that is hemoglobin and related things, that we have covered in the last class. So today we will see some details of other important aspects of CBC in the childhood clinical practice. Okay, now CBC will give maximum information regarding the clinical condition, although most of the time it is overlooked. Many times we don't have time to look into that, or we don't have any interpretation, और हमें जो इसके बारे में पता नहीं है, because of so many reasons we will going to neglect the simple CBC report. But otherwise, if you thoroughly analyze the CBC report, that itself gives the maximum information. Okay, now when we get a CBC report, most of the time what happens, generally it gives knowledge about three important things as I described earlier. One is it gives information about the RBC series that we have discussed in the last class. It may be HP percentage, RBC count, or hematocrit value, then MCV, MCHC, okay, or MCH, etc. That part we have already covered. Second important domain that a CBC gives information is about the WBC count. WBC count means WBC and differential count. WBC is lymphocytes, so they are produced from the lymphoid tissues present in the bone marrow. The stem cells which are producing the lymphocyte series of cells are called as lymphoid series or lymphoid cells, lymphoid stem cells. From them actually all the RBC series will go into produce. Another information it gives is about the domain related to platelets. Okay, so it gives the information of the platelets, and it gives a mean platelet count. It also gives the information regarding immature platelet fraction. Many times this is very important. Some of the disorders like dengue and all, or some of the other bleeding and clotting disorders, IPF is very important. IPF means immature platelet fraction. Now just like in the RBC, we know that reticulocytes are there. isn't it? Previously there is erythroblast. Erythroblast is get converted into early normoblast. From the early normoblast, there is production of the intermediate normoblast. From the intermediate normoblast, there is production of the normoblast or late normoblast. Then there is a production of a reticulocyte. From the reticulocyte, RBC will produce. Now, till reticulocyte, the production takes place inside the bone marrow. And only the mature reticulocytes, so they will go into release into the blood. So what I mean to say is reticulocyte, when we talk about RBCs, reticulocyte gives a very good information regarding what is happening inside the bone marrow. If the reticulocyte count is okay, the bone marrow is okay, because the until the formation of the reticulocytes, the things are going on inside the bone marrow. Only the mature RBC will come into the blood circulation. Usually reticulocytes come into the circulation and they get mature into RBC. So that is the importance of reticulocyte. Similarly, this is for the RBC side. Similarly, for the platelets domain, it is IPF, immature platelet fraction. Immature platelet fraction is present in the bone marrow and now is about to release into the blood. So once you calculate the IPF, then again you come to know that what is the situation inside the bone marrow with respect to platelet count. So therefore IPF, this also gives information, and this is also present in the CBC. Okay, so similarly now we go further. See, this is a case report analysis if you see. So this is most of the time you have seen so many such investigations, isn't it? Now, see, this is a series for the WBC, okay, a lymphocyte series, lymphocyte, and the last one, this is a series for MCHC, MCH, this is for the RBC, and in between we will have for the platelets. Now, what is important is the graph which is given below. This particular graph also gives much information. इसके बारे में हम बाद में देखेंगे one by one. Now, a few words about this graph which is given. Everybody has been seen, I hope you have seen this graph, but actually we don't know how to interpret this graph for our benefit. Now if you look into this slide, the graphs which are given below, that will give a very good information. Okay, so what I mean to say is, first one is platelet volume distribution, second one is WBC distribution, I think. The second one is RBC volume distribution, and third one is WBC volume distribution. Now these graphs actually give the idea of a volume distribution. Okay, volume distribution. Now if the spikes are broad, just as given here, if the spikes are broad, okay, if the spikes are broad, then it suggests that if the spikes are broad, then it suggests that RDW is less. ओके, इज स्पाइक्स, अगर इसका स्पाइस अगर ब्रॉड हो गया तो इसका मतलब है रेड सेल डिस्ट्रीब्यूशन जो है, जैसे यहाँ पे रेड सेल डिस्ट्रीब्यूशन जो है वो कम है. अगर इसका बेस वाइड हो गया तो इसका मतलब है रेड सेल डिस्ट्रीब्यूशन इज मोर. इफ द बेस इज मोर वाइडर like this, the base is more wider here, but if you see here the spikes is here, the spikes is more wider. If the base is wider, it suggests that RBW is more. If the spikes is more wider, then it suggests that RDW, red cell distribution width, is less. Anyway, we will further look into that, then the things will be clear. Now if you look into this slide now, how to read the CBC, how to read the CBC. Always look the CBC cell line by cell line. ठीक है, हमेशा CBC को इन जनरली देखना नहीं है, सेल लाइन बाय सेल लाइन देखना है आपको. पहले RBC का सेल लाइन देखो, उसके बाद WBC का सेल लाइन, एंड देन गो फॉर द प्लेटलेट सेल लाइन एंड कंपेयर दैट. RBC series means we have got HB count, RBC count, MCV, MCH, MCSC, then RDW, and also then RDW. Okay, now if you go for the WBC series, in the WBC series again we have got total blood WBC count, differential count is there, absolute neutrophil count is there, ANC, absolute neutrophil count, okay, ALC, absolute leukocyte count. So these are the WBC series. Similarly in the platelets, if you see total platelet count is there, Okay, mean platelet volume is there, and immature platelet fraction is there, IPF is there. So now what you have to do is interpret all together now. Okay, now when you interpret all together, for example, if RBC cell series is also showing downfall, WBC series is also showing downfall, and platelet series is also showing downfall, it very clearly suggests that there is some problem in the bone marrow house itself, and it is not producing any of the cells. So this may be because of the picture is considered as pancytopenia. Pan means all, as a whole. Cytopenia means less number of cells. So सभी cells का number कम हुआ है. Pancytopenia will be there. So this may be seen in case of leukemia. So this may be also seen in case of aplastic anemias. Anyway, the problem is present in the bone marrow house itself. Now if you look into the peripheral smear, this is also one of the important part of the CBC, peripheral smear. In the peripheral smear, this also gives the maximum information. Peripheral smear gives the information of RBC morphology. RBC का size क्या है, RBC का shape क्या है, sickle shape है, round shape है, spherical shape है, sickle shape है, ठीक है, या bicount के shape है. So it gives a lot of information. Poikilocytosis है, Barr cells है. So it gives them many information. Similarly, in the peripheral smear, you also get the information about the WBC, and you can get that कि न्यूट्रोफिल है, न्यूट्रोफिल का लोब्स कितना है. इफ द न्यूट्रोफिल का टोटल लोब शुरू में ज़्यादा रहता है और उसके बाद उसका लोब्स कम होता जाता है. इमेच्योर न्यूट्रोफिल कंटेन्स ओनली 6 or 7 लोब्स, whereas इमेच्योर न्यूट्रोफिल्स दे कंटेन मेनी लोब्स, और बीच में एक राउंड शेप भी आ जाता है जिसको हम बोलते हैं बैंड सेल. सो इफ यू फाइंड सच मोर नंबर ऑफ लोब्स इन द न्यूट्रोफिल, देन इट इज इमेच्योर, एंड बैंड सेल इज अगेन इट इज इमेच्योर. अगर मेच्योर न्यूट्रोफिल है, इट कंटेन्स लेस लोब्स. Okay, 5 to 6 lobes will be there. Then platelet number, okay, size and clumping of the platelets, parasites, abnormal cells. So all these things can be seen in simple peripheral smear. Simple peripheral smear. As I told earlier, reticulocyte count. Reticulocyte count gives a very good information of the bone marrow house. Similarly, IPF, immature platelet fraction also. Now, if the reticulocyte count is high, that means if the reticulocyte count is high or normal, then it suggests that bone marrow is normal. Okay, and now suppose if after you start reticulocyte count is low, now patient is diagnosed as iron deficiency anemia, and you started giving the iron supplementation, and after 1 week or 2 weeks of iron supplementation, if the reticulocyte count is increasing, so that suggests that it is only because of iron deficiency and bone marrow house is normal. Okay, if even after giving the iron supplementation also, if the reticulocyte count is not increasing, so that suggests that the problem is not with the iron, and the problem is something with the bone marrow itself, that bone marrow itself is not producing the good amount of reticulocyte. So this also helps for the differential diagnosis. Okay, now anyway, we will see one by one. First, we will look into some of the cases, and then we will try to understand this in a very clear way. Now, first look into this case. An 8-year-old child, female girl, and she has got the pallor since last 3 years. Since last 3 years. Yes, of course, little chronic it is, 3 years. And there is also diarrhea off and on. Off and on, there is diarrhea is also there. And she hails from Rajasthan. Okay, so she hails from Rajasthan. You can take any North Indian state, and she is taking some iron for the pallor since so many days, since so many years, you can say, or months. She is taking iron for the pallor, but there is no much response. There is no much response. Now on examination, the pallor is plus. On examination, the pallor is plus. And in the meantime, she is also stunted, and she is also undernourished. She is also undernourished. And the picture is shown, and she is under height, and there is also platinacea. That means nail changes are evident. Cholinacea is also there, suggestive of iron deficiency anemia. Pallor is there. Pallor means there is definitely anemia is there. Now we have to look into that, whether it is a nutritional or iron deficiency anemia or some other anemias. there is no lymphadenopathy. There is no lymphadenopathy. So can anybody's, now we will look into the CBC later. Just looking at this case, do you have any interpretation? Because we have seen so many cases, isn't it? 8-year-old child, female, pallor is there, diarrhea is also there off and on. She is from Rajasthan and she is stunted. She is also undernourished. Okay, height and weight is less. Nail changes are evident. And what may be the underlying problem? One thing is sure, she is having anemia. Everybody knows. What may be the underlying problem? Can anybody say? Just by using your previous knowledge, by looking at this case.
मे बी सीलियक डिजीज सर, क्योंकि क्रोनिक है, क्रोनिक के वजह से इसका वेट और हाइट दोनों है, तो ये स्टंटिंग में है ना। और उसके साथ साथ एक चीज और है, प्लेटिन किया और कोलिन किया, ये भी प्रोलॉन्ग जो है डेफिशिएंसी बता रहे हैं, है ना सर।
वेरी गुड।
बाकी डायरिया ऑन एंड ऑफ हो रहा है जो सीलियक डिजीज की तरफ बता रहा है, इसका कोई और कॉज नहीं दिया। अपने आप मान लो उसने खाना बंद किया तो थोड़ी देर के लिए, कुछ दिन के लिए सही होता है। बाकी
ओके, वेरी गुड, वेरी गुड, गुड, वेरी गुड।
राजस्थान से बिलोंग करती है, राजस्थान जो है यहाँ पे, राजस्थान में ये प्रोमिनेंट एक डिजीज है।
वेरी गुड इमेजिनेशन। ओके, एनी अदर आइडियाज? Okay, now we will look into the CBC report. Okay, see, this is a CBC report of that particular patient. Now tell me what's there in this report. Investigation show HB is 4.4 and MCV is 56, MCH is 20, MCHC is 23, RDW is 25. Okay, then comes ferritin is 2 Ng per ml low. And the peripheral picture shows that microcytic hypochromic, WBC is 6800, polymorphous is 56, lymphocytes 40, monocytes 4, platelets 4.5 lakhs, reticulocyte 1.2. So now tell me what's your diagnosis. Last class we have seen about everything about the RBC, and based on that now comment on the RBC domain.
इन वैल्यूज के अकॉर्डिंग तो इसने निकाल लिया ना, इसने माइक्रोसाइटिक हाइपोक्रोमिक है, क्योंकि एमसीवी भी कम है, एमसीएच भी कम और एमसीएचसी भी कम है।
ओके, एचबी, व्हाट शुड बी द एचबी परसेंटेज नॉर्मली?
एचबी भी कम है,
एचबी ड्रास्टिकली कम है, 15 ग्राम से अब लेके जाएंगे तो it's very drastically कम है. So accordingly MCV is also less. The normal MCV is about 9, how much?
90.
MCV 90
FL है. Then comes MCH. Normal MCH is about 30
picogram,
and MCHC is about 33%.
33.
It is only 23%. And RDW is less. RDW is 25. So red cell distribution is also less. Okay, ferritin तो वैसे ही कम है. So peripheral picture shows the microcytic hypochromic anemia. So microcytic hypochromic anemia is very characteristic feature of a iron deficiency anemia, but provided it can be also seen in case of a thalassemia, that has to be kept in mind. Otherwise it's very typically seen in case of microcytic hypochromic anemia. And what about the WBC domain? See, you look into the WBC domain, it's almost all normal, isn't it? So WBC is more than 5,000, that's 6,800, it's quite normal. Polymorphous 56, lymphocyte 40, monocyte 4, even the platelet is almost near normal, no problem. And what about the reticulocyte? What is the normal reticulocyte count? Yes, reticulocyte is now low. Do you know what is the normal reticulocyte count? See, this is a picture. Again, we will see the reticulocyte. This is a picture of this particular patient anyway. Now we will look into the comments or analysis of this patient. Child has got stunting, not responding to iron. See, one of the important thing is there, it is not responding to iron, isn't it? Your diagnosis and my diagnosis is iron deficiency anemia, no doubt. But if you look into the case, in the case it is very clearly told that this child is not responding for iron. She is taking iron since so many months, but she is not responding, because if she is responding for iron, the reticulocyte count should increase. रेटिकुलोसाइट से नेक्स्ट जो आरबीसी बनता है, और रेटिकुलोसाइट ही नहीं बनता है तो आरबीसी कैसे बनेगा? तो एक्चुअली रेटिकुलोसाइट काउंट इज नॉट इंक्रीजिंग, इट इज स्टिल 1.2. ओके, सो चाइल्ड इज टेकिंग आयरन and the blood picture is suggestive of iron deficiency anemia, no doubt. But thing is, she is not responding for iron. Now the question is, remember, 8-year-old child, this is the 8-year-old child, this is not the age for nutritional anemia. Okay, nutritional anemia का एज नहीं है 8 साल, ठीक है, 5 साल, 3 साल, 4 साल, 5 साल, सो ये सब है. 8 साल में जो है वो एक टिपिकली न्यूट्रिशनल एनीमिया का एज नहीं है, बिकॉज 8 साल में तो बच्चे खा लेते हैं अच्छे से, ठीक है. बच्चों खाने में दिक्कत कब होते हैं? इन द थर्ड ईयर, फोर्थ ईयर, फिफ्थ ईयर, सो देयर विल बी सम प्रॉब्लम. सो दैट टाइम इट मे लिस्ट न्यूट्रिशनल एनीमिया, बट 8 ईयर इज एक्चुअली नॉट सच ए कॉमन एज फॉर न्यूट्रिशनल एनीमिया. सो इफ द आयरन डिफिशियंसी इज देयर, वन थिंग इज वेरी क्लियर, वी हैव टू थिंक दैट दिस इज नॉट बिकॉज ऑफ न्यूट्रिशनल एनीमिया. आयरन कम होने के वजह से ये एनीमिया नहीं है, क्योंकि एज के हिसाब से आप देखेंगे तो. सो नाउ यू हैव टू स्टार्ट थिंकिंग इन अदर वे. Okay, if it is not iron deficiency anemia because of nutritional cause, it may be iron deficiency anemia because of some other secondary cause apart from nutrition, because it is not responding for iron, है ना. अगर आयरन का कमी है तो आयरन देते ही वो रेस्पॉन्ड करना चाहिए था. अब कुछ और हो सकता है जिसकी वजह से बॉडी से आरबीसी का लॉस हो रहा है या हीमोग्लोबिन का लॉस हो रहा है, या दैट मे बी द कॉज. सो लेट अस डिस्कस अबाउट दैट. नाउ एट दिस पर्टिकुलर एज, what are the commonest secondary causes for the iron deficiency anemia? There are many causes. At the 8 year of age, any bleeding taking place from the body, elsewhere part of the body, maybe like Meckel's diverticulum, or there may be epistaxis, there may be some polyps, there may be some diverticulitis. Okay, so there may be some ulcers, then there may be some AV malformations, arteriovenous malformations, hemosiderosis like conditions, or hematuria, or certain malabsorption syndromes. Okay, we know that pallor is one of the most common symptom in case of celiac disease. Okay, malabsorption syndromes like celiac disease may be there, trophical sprue may be there, worms may be there, Crohn's disease may be there, or ulcerative colitis may be there. So now if she is responding for iron, everything is fine and fit, is leave it, diagnosis is over. Okay, but if she is not responding to iron, now we have to think in other way. यहाँ पे तो respond नहीं कर रही है because 2 साल से उसको problem है. So now you have to think about the secondary. These are all the secondary causes of iron deficiency because blood has been lost from one or the other sides. So now 3 things that we have to think in this case is striking. Number 1 is there is low HB which is not responding for iron therapy. Number 2 is she is badly having the stenting and chronic onset, and she is from Rajasthan. So what you have to now do is, as you told very well, so this may be a case of celiac disease. Okay, so because all the 3 things are matching, then TTG, endomysial antibody, gliadin antibodies, and duodenal biopsy. Okay, so these are the benchmark investigations that you have to go for. Okay, so actually this is a case of celiac disease. This is a case of celiac disease with the chronic malnutrition and also stunting. Now look at the finding. हमें तो CBC देखना है ना. So when we look into the DD of microcytic hypochromic anemia, following are the differential diagnoses. And मैंने last class में भी बताया था. So when we have got microcytic hypochromic anemia, microcytic means size कम है, hypochromic means color कम है. Okay, usually it is seen in iron deficiency anemia. And such presentation can be also seen in case of anemia of any chronic inflammation. दिस मे बी सीन इन केस ऑफ आयरन डिफिशियंसी एंड क्रॉनिक इन्फेक्शन, कॉम्बिनेशन में भी मिल सकता है. एंड वन मोर पॉसिबिलिटी एज आई टोल्ड ऑलरेडी, दैट इज थैलेसीमिया माइनर, and this may be also seen in sideroblastic anemia. You may be knowing in case of sideroblastic anemia, आयरन का जो रिंग है ना, सो वो नहीं बन पाता है. माइटोकॉन्ड्रिया के अंदर जो बनता है वो क्या आपको पोरफायरिन वो सब है ना, वो सब उसका रिंग बनता है. एक हीम मॉलिक्यूल का एक रिंग बनता है, ग्लोबिन का नहीं, हीम का. उसके अंदर हीम का एक मॉलिक्यूल जाके वहाँ पे फिट होके बैठ जाता है. So that's a problem in case of sideroblastic. Okay, heme is not completely formed. Heme molecule is, although iron is there, the heme molecule itself is not formed because of some of the genetic problems, etc. And that condition is called as sideroblastic anemia. Sideroblastic anemia. So simply hypochromic microcytic anemia जब आएगा, so these are all the possibilities. Number one is iron deficiency anemia. Number one. Number two, any chronic inflammation, in any of the chronic inflammatory disease अगर चल रहा है, so that may be there, or it may be there in iron deficiency and chronic infection both. Then thalassemia minor, and last one is sideroblastic anemia. So now in this case, if you see about the RDW, now comes the importance of RDW, red cell distribution width. Now red cell distribution width will going to help us to differentiate between the different types of microcytic anemia. ठीक है, अब माइक्रोसाइटिक एनीमिया हमने देखा कि अलग अलग जगह में मिल रहा है ना, कि थैलेसीमिया में मिल रहा है, सिडरोब्लास्टिक में मिल रहा है, आयरन डेफिशिएंसी में मिल रहा है, क्रॉनिक इन्फेक्शन में भी मिल रहा है. तो हम कैसे बोलेंगे कि ये माइक्रोसाइटिक एनीमिया जो है ओनली आयरन डेफिशिएंसी है? सो नाउ कम्स रेड सेल डिस्ट्रीब्यूशन विड्थ. Okay, so now red cell distribution width is a coefficient of variation in the red cell volume distribution. Okay, red cell volume distribution, a given sample में how much is a percentage of microcyte, how much is a percentage of macrocyte, how much is a percentage of megalocytes. So this is given by RDW. Okay, and it is an objective evidence of anisocytosis. Anisocytosis means अलग अलग टाइप का सेल्स है, आरबीसी है, अलग अलग शेप है, अलग साइज है, seen on the peripheral smear. So RDW, the normal range is 11.5 to 14.5. 11.5 to 14.5. This is a normal range of RDW in a normal condition. Okay. Now in this case, I think if you see, RDW has been given something as दिया था ना 25. RDW is 25. Here they are telling that RDW normal is 11 to 14.5. Now here the red cell distribution width that has been increased a lot. So how you will going to interpret now? Yes, again you come to this particular table. This also gives much information. RDW is normal. Okay, RDW low MCV, normal MCV, and high MCV. Now we have to look into MCV, mean corpuscular volume. We know that what do you mean by mean corpuscular volume? It is a volume which is occupied by the single RBC. अगर वो मैक्रोसाइट होगा तो वो ज़्यादा वॉल्यूम को ऑक्यूपाई करेगा, अगर माइक्रोसाइट होगा तो कम वॉल्यूम को वो ऑक्यूपाई करेगा. उसके बाद RDW क्या करता है? अगर कोई भी कंडीशन है जहाँ पे नॉर्मल RDW है, RDW नॉर्मल है, रेड सेल डिस्ट्रीब्यूशन नॉर्मल है, बट MCV कम है, MCV कम है, so then it suggests thalassemia trait. Similarly, RDW is normal and MCV is also normal, then it is a normal condition, no doubt, कोई दिक्कत नहीं है. Okay, if the RDW is normal and MCV is high, MCV बहुत हाई है, मतलब मेगलोब्लास्ट है या मैक्रोसाइट्स है, इस तरीके से, so then it indicates the liver problem or aplastic anemia etc. problem. So this particular table is quite useful. Okay, so this is one. Normal RDW है, low MCV है, thalassemia. नॉर्मल RDW है, नॉर्मल MCV है, नॉर्मल. नॉर्मल आरडीडब्ल्यू, हाई एमसीवी है लीवर और एप्लास्टिक एनीमिया, बोन मैरो प्रॉब्लम्स. कम टू द नेक्स्ट पार्ट. इफ यू हैव अ हाई आरडीडब्ल्यू है, इफ द आरडीडब्ल्यू इज हाई एंड एमसीवी इज लेस, देन इट इज आईडीए. एमसीवी इज लेस मतलब माइक्रोसाइटिक, सो दैट इज एन आईडीए. बट उसका करेक्शन के लिए क्या चाहिए हमें, मतलब उसका सब्सटेंशिएशन के लिए हाई आरडीडब्ल्यू, रेड सेल डिस्ट्रीब्यूशन विथ इंक्रीज्ड. वो डिस्ट्रीब्यूशन जो गिवन अमाउंट ऑफ, इसमें जो है जो रेड सेल आरबीसी का डिस्ट्रीब्यूशन जो विड्थ है वो बड़ा हुआ है. आयरन डेफिशिएंसी में जब उसका साइज बड़ा है, साइज छोटा है, तो डिस्ट्रीब्यूशन वाला ये तो पड़ेगा ही. ठीक है. सो कितना एरिया में वो टोटली ऑक्यूपाई किया वो तो बढ़ेगा क्योंकि छोटा है ना उसका साइज. सो देयरफॉर हाई आरडीडब्ल्यू विद लो एमसीवी इज सजेस्टिव ऑफ आयरन डेफिशिएंसी एनीमिया. ऑलवेज रिमेंबर, इसको प्रिंट कर दो मन में, ठीक है, दिमाग में. हाई आरडीडब्ल्यू विद लो एमसीवी आईडीए. तो आपको आयरन डिफिशिएंसी एनीमिया बोलने के लिए सिर्फ एमसीवी पॉसिबल नहीं है. आरडीडब्ल्यू, हाई आरडीडब्ल्यू विद लो एमसीवी इज आयरन डेफिशिएंसी एनीमिया. हाई आरडीडब्ल्यू विद नॉर्मल एमसीवी, यस, नाउ दिस इज इंपॉर्टेंट. हाई आरडीडब्ल्यू है और नॉर्मल एमसीवी है. आरडीडब्ल्यू क्या है? इट हेल्प्स टू आइडेंटिफाई डिफरेंट टाइप्स ऑफ द सेल्स. ठीक है. वो बड़ा सेल्स है, छोटा सेल है, इरेगुलर सेल है, ये पता चलेगा. ये बड़ा सेल है, इरेगुलर सेल है, ये कब पता चलेगा, किस में मिलेगा आपको? सिकल सेल एनीमिया में सिकल शेप आरबीसी मिलेगा. ठीक है. मैलिग्नेंसी में कुछ अलग मिलेगा, क्रॉनिक लिवर डिसीज में कुछ अलग मिलेगा, स्पिरोसाइट्स में जो है राउंड शेप मिलेगा. ठीक है. तो सिकल शेप में सिकल सेल मिलेगा. सो अलग अलग टाइप का तो मिलेगा. ठीक है. सो नाउ हाई आरडीडब्ल्यू with the low MCV is IDA, high RDW with the normal MCV is sickle, CLD, malignancy, etc. Okay, high RDW with the high MCV, that is seen in case of megaloblastic anemia. Okay, megaloblastic anemia. So this chart to some extent you have to remember. This is quite interesting. Commonly जो हमें मिलता है कंडीशन, दो कंडीशन है बच्चों में देखना होता है. एक जो है सिकल सेल एनीमिया वाला, क्योंकि हाइपोक्रोमिक माइक्रोसाइटिक एनीमिया एक तो मिलता है थैलेसीमिया में, एक तो मिलता है आयरन डिफिशिएंसी एनीमिया में मोस्ट कॉमनली. तो आयरन डिफिशिएंसी एनीमिया में हाई आरडीडब्ल्यू विद लो एमसीवी. ठीक है. सिकल सेल या इसमें सब क्या होता है कि हाई आरडीडब्ल्यू विद नॉर्मल एमसीवी. ठीक है. क्योंकि वो ज़्यादा स्पेस को ऑक्यूपाई कर रहे हैं ना, छोटा नहीं है उसका साइज, है ना, कि सिकल सेल हो गया या जो भी है सेल्स हो गया. माइक्रोसाइट में तो उसका साइज छोटा है. मेगलोब्लास्टिक में हाई एमसीवी, मेगलो मतलब बड़ा सेल, एमसीवी बहुत हाई मिलेगा और रेड सेल डिस्ट्रीब्यूशन विड्थ भी हाई मिलेगा. दैट्स ऑल. दिस इज वन ऑफ द सिंपल केस विच हेल्प्स टू आइडेंटिफाई दिस टू. सो थैलेसीमिया, टॉकिंग अबाउट थैलेसीमिया, थैलेसीमिया में क्या मिलेगा? वी हैव गॉट अ हाइपोक्रोमिक माइक्रोसाइटिक एनीमिया, थैलेसीमिया में मिलेगा, आयरन डिफिशिएंसी एनीमिया में मिलेगा. बट आयरन डिफिशिएंसी एनीमिया में लो एमसीवी विद हाई आरडीडब्ल्यू मिलेगा, बट थैलेसीमिया में हाई आरडीडब्ल्यू विद नॉर्मल एमसीवी मिलेगा, नॉर्मल एमसीवी मिलेगा. अगर मेगालोब्लास्टिक का बात करते हैं तो हाई आरडीडब्ल्यू विद हाई एमसीवी मिलेगा. मैक्रोसाइट और कोई विटामिन B12 डिफिशिएंसी है, एक्चुअली B12 डिफिशिएंसी, फोलिक एसिड डिफिशिएंसी, इट लीड्स टू मेगालोब्लास्टिक एनीमिया. और मैक्रोसाइट्स, अदर मैक्रोसाइट जो भी कंडीशन है जहाँ पे मैक्रोसाइट्स बनता है, आरबीसी का मेचुरेशन टाइप नहीं होता है, मतलब आरबीसी बड़ा ही रहता है. ठीक है. तो 7 माइक्रोन तक नहीं आता है, वो बड़ा ही रहता है, लेट नॉर्मोब्लास्ट, इंटरमीडिएट नॉर्मोब्लास्ट. तो वहाँ पे भी आपको मैक्रोसाइट्स मिलेगा बिकॉज ऑफ B12 एंड एज वेल एज फोलिक एसिड प्रॉब्लम्स deficiency. There is also you are getting high MCV. So this is one of the interesting case. So now to conclude here, if you see, so high RDW with low MCV is iron deficiency anemia, whereas high RDW with high MCV is a megaloblastic anemia. Similarly, normal RDW with high MCV is seen in liver disease, हम डिस्कस कर चुके हैं, and aplastic anemia, while normal RDW with the low MCV is thalassemia. Okay, there is a, इसमें जो है ना, जो मैंने बोला उसमें एक करेक्शन है. Okay, so high RDW with the normal MCV is seen in sickle and malignancy cells etc. एक हमें important जो correction माने जो differential diagnosis है thalassemia. So what they are telling is, in case of thalassemia, normal RDW with low similarly normal RDW with high MCV is seen in liver disease and aplastic anemia, while normal RDW with low MCV is seen in thalassemia. High RDW with low MCV is iron deficiency anemia, and high RDW with high MCV is seen in megaloblastic anemia. Okay, but still it is not clear about the thalassemia. Anyway, our patient is having high RDW 25 years का and low MCV. MCV तो हमने देखा low है वो 20 के कुछ 50 के आसपास था. So it is IDA, iron deficiency anemia. High RDW with low MCV, that is iron deficiency anemia, due to secondary cause like celiac disease. The cause is celiac disease. Of course, I know that in this particular case, how to differentiate thalassemia is not clear. For that we will again discuss another case. There it will be very clear. है ना, वो case में हम देखेंगे, then it will be clear. So this is about the case number 1. Now, how to treat this condition? How to treat this condition? Oral iron should be given for 3 to 6 months. Then later also you continue the iron. Iron आपको 2-3 महीने तक देना है, क्योंकि हमको स्टोर को भी भरना है. अगर एनीमिया हुआ है आयरन का मतलब स्टोर में भी खत्म हो गया. ठीक है, so you have to fill the store also. So then one is oral iron should be given, deworming should be given, diet modification should be done, and treatment of the mother, if the mother is breastfeeding, should be done, and also stop the bottle feeding. When you suspect that iron deficiency is primary or secondary, primary iron deficiency is common in the early age. ठीक है, जो मैंने बताया 2 साल 3 साल 4 साल में early age, and if it is more than 5 years, child is more than 5 years, then always suspect the secondary cause. Okay, then it should be considered as secondary if it is not responding to oral iron. I told already, it should be considered as secondary if it is not responding for oral iron. And if there is symptoms and signs other than the anemia, if there is symptoms and signs other than anemia like diarrhea or stunting as happening in this child, then there is also requirement of the blood transfusion. If you see the HB in this case it's 4.4, it may require even the blood transfusion to give some immediate effect. So how many days we have to send the stool for occult blood to see that, particularly GIT bleeding. अगर GIT bleeding में जो है GIT bleeding चल रहा है और blood जो है स्टूल में ऑकर्टली जा रहा है, तो इसको आइडेंटिफाई करना है तो एक बार स्टूल भेजने से नहीं पता चलेगा. फॉर एग्जांपल वर्म इन्फेस्टेशन होगा, मैकस डाइवर्टिकुलम होगा, या और कोई दिक्कत होगा, अल्सरेटिव कोलाइटिस, वेयर द ब्लड इज पासिंग ऑकल्टली थ्रू द स्टूल एंड देयरफॉर एनीमिया इज कमिंग. एक्चुअली स्टूल वी हैव टू सेंड. स्टूल 1 या 2 बार भेजने से नहीं होता है. इट्स टोल्ड दैट 3 to 5 times 5 days continuously you have to send the stool. Then only occult bleeding will be identified in the stool. एक बार भेजने से कुछ नहीं पता चलता है. So if you look into this, the things are very clear. Now this is microcytic hypochromic picture if you see in the peripheral blood picture. ठीक है, so microcytic hypochromic picture. Now the RBCs are seen over here. ठीक है, the central paleness will be seen. As I told earlier, centrally it is pale and peripherally it is pink. You can see peripherally it is pink and centrally it is pale. But it is a hypochromic. जो कलरिंग है, कलर जो होना जितना पिंक होना चाहिए उतना पिंक नहीं है. And looking into the size, it is also microcytic. It is also microcytic. So this is a typical picture of microcytic hypochromic anemia. Now, one thing is left, that is about the thalassemia. I told thalassemia, differentiation of the thalassemia is quite difficult. Can you say iron deficiency anemia कौन सा पिक्चर में लगा? High RDW with the low MCV. Okay, so now high RDW with the low MCV or normal MCV can be seen in case of thalassemia also. So how to differentiate? Then we have to go for serum iron binding capacity. So that will going to help us between these two, or RBC fragility test. So these are some of the investigation that helps to differentiate thalassemia. Otherwise, differentiation of thalassemia is very, very difficult. आयरन डेफिशिएंसी एनीमिया में सीरम आयरन कम होगा, सीरम आयरन बाइंडिंग कैपेसिटी ज़्यादा होगा, ठीक है। थैलेसीमिया में सीरम आयरन बड़ा होगा, सीरम आयरन बाइंडिंग कैपेसिटी कम होगा, और आरबीसी फ्रेजिलिटी टेस्ट पॉजिटिव रहेगा. सो दिस इज वेरी वेरी यूजफुल investigation to differentiate from thalassemia. Otherwise, many times there is a chance that you wrongly diagnose thalassemia as iron deficiency anemia and start with the iron syrup. I told already, in case of thalassemia, there is already more iron in the blood, and if you are again going for iron syrup, then it's a big blunder. It's a big blunder. So always before starting the iron therapy, always confirm the case for thalassemia. If it's not thalassemia, then you go for it. Now, Ayurveda always talks about the different types of the deshas, isn't it? Purva desha, Pakshima desha, Uttara desha, and many things. Even Charaka says the Panchanadi Pradesha, it is more known for the hemolytic disorders. Rakta Pitta Adhyaya has been explained in the bank of river in the Panchanada Pradesha. That is nothing but Punjab, Sindh area. Okay, where the hemolytic disorders are more. Similarly, Kashyapa also gives many explanations like Purva Desha, Pakshima Desha in the last chapter of Kilasthana. Now, Desha-wise, there is a distribution, geographical distribution is there. Now, beta thalassemia is quite common in Sindhi and Punjabi population. So, this is a useful criteria. So, if you are practicing there, okay, then before starting the iron treatment, please confirm that. Sickle cell disease, sickle cell anemia, so this is quite common in the tribal areas. So some of the tribal areas of Nagpur, Chhattisgarh, Gujarat, and in Mysore, in the Mysore HD Kote area is there, Karnataka. So that is also a very common endemic area for sickle cell disease. Similarly, J6PD disease, this is one more disease which is common in Parsi population, Kutch population, and Bhanushalis. So HBD disease is there in North India, especially Punjabis. HBE disease in Northeast India like Bengal and Assam, etc. So this is the geographical distribution of some of the hemolytic disorders. Okay, so actually some of the pictures, especially thalassemia, shows like that of the iron deficiency anemia. Now other disorders like spirocytic anemia, sideroblastic anemia, how to differentiate that I have shown in the table. So this is how this particular RDW and RBC indices combination that will going to help us to identify so many disorders. So I hope you understood this first case, and now we move on to the next case.